Welcome, everybody. I'm Mara Yale, and I'm really pleased to have you here to focus on our topic today of constraint-induced movement therapy. And we're excited to learn together. And I have some slides that I'll share to get us started to orient us to the educational series that we here at Pediatric Stroke Network offer and run for families and providers. And then we'll move right into our presentation. So as I mentioned, the topic today is constraint-induced movement therapy, and you'll learn a lot more about that from Maria and from Cassie. We here are offering support to families affected by pediatric stroke or brain injury. And many people start with a hospital stay or a hospital visit to a clinic for a diagnosis. But as we know, a stroke in early life can affect the whole lifespan. And a lot of what we focus on here in our educational series is on life beyond the clinical acute setting. Just as a reminder, what we're offering is educational for your information, and especially when we get into the discussion, we ask that you make questions as general as possible, because if you have specific questions about your child, we really encourage you to seek professional guidance from your healthcare providers. So where have we been? Where are we going? Well, you'll see some evidence of how constraint-induced movement therapy helps promote growth and development in young children. Every one of our webinars is about some aspect of development in children affected by brain injury. And we've been actively building community through education for 6 years now. You'll find more than 50 videos on our YouTube channel, and they're viewed internationally by a wide audience. And we continue to collaborate and partner with speakers around the country and around the world. I'll drop the links into the chat so you can find past and future events. Just to give you a sense of the scope of what we've covered this year, we talked about how children can benefit from being part of a sports team through team impact, how to choose therapies for upper extremity function. Constraint is just one, but there are others. And then neurotech, enhancing life participation, learning to drive for our older teens, and play, how play can be therapeutic, and just last week, reading. So if any of those topics or many, many dozen more topics are of interest, we'll really encourage you to check them out. And for those who are in or near Boston, we have our in-person event. It's our 4th annual Play to Thrive Festival. It was supposed to be earlier in May, but the weather has pushed it to June 21st. So we invite you to come play and join us for that. Again, I'll put these links in the chat so you can find them there. I'll hold this here for just a minute. So if you want to pull up the QR code to the link, you can, and hand off to Cassie, who's going to present the story from her perspective as a parent to a child who participated in iAcquire, which is actually a phase 3 clinical trial for constraint-induced movement therapy, a particular kind of that you'll learn a lot more about from Maria. So Cassie, please share any experiences you had with your son.
Okay, there we go. So yeah, when he was about a year and a half old, my first steps therapist that he had, they were the ones who recommended it to me just to see if he could get in. And based on his condition that he had a hemorrhagic stroke in the womb, and we didn't know what kind of stroke or what caused it, but based on what the doctor said when we tried out for this iAcquire study, is it could have been from a blood clot that bursted, and he was accepted. And we ended up getting into the 6-hour group, which is a lot. There is just regular, the 3-hour, or the 6-hour. And with the 6-hour, I had to take off work. I had to change my schedule and do all that to make sure he could do it, but it was the best thing that I could have done for him as someone myself who has had a condition due to a stroke in the womb. Seeing the progress that has been made over the last 20 years and what we are doing to help our kids is amazing. He was only in it for a month, and every day you could see him doing more and getting stronger and not getting as disappointed in himself when he couldn't do something. He was actually wanting to keep trying, and he still does. When he realizes he's not able to do something the normal way, he is actually trying to figure out how he can do it. And I don't remember doing that at 3 like he is. I remember doing that later on in life and being like, oh, I can't reach that. Well, I'll just climb. Or I can't hold on to this. What can I do? And he is doing that now, and it's because I remember seeing a bunch of kids being able to do everything the same way. And that's the one thing is our kids they might be able to do some things just like everybody else, but there's a good chance they won't. And that's okay. It's helping them find ways that they can do it themselves. I remember I was so worried that I wouldn't be able to drive because everything is right-handed, and that was my side that was affected. But with therapies and all that, I did do the things that I can do now. I gave birth to a beautiful kid, and I feel the fact that I went through it helps me help him and to make sure that he gets more help than I was able to get. Because like I said, in the last 20 so years and more, the programs and the help and the resources have grown so much. Because I remember when my mom got me into First Steps, it just started. And now he is doing so awesome, and I can't wait for the next study that he is going to be able to be a part of to keep helping him strive to be the very best that he can be.
Thanks so much. Your perseverance, even in this webinar setting. So we invite you to listen, and we'll hear from Maria now, and then Cassie will stay on for our discussion at the end as well.
Thanks, Cassie. Okay, I will pull up that presentation. So thank you again for inviting me to have the opportunity to get to talk to everyone about constraint-induced movement therapy. A little bit, so you got to hear from Cassie, so a little bit about me. I am an occupational therapist. I've been an occupational therapist for over 7 years. I wear different hats. You'll get to see a video of me in iAcquire, working with a participant that the family was okay with me sharing some video, but I don't have any photos of me. So that middle photo is actually me getting to share some of the skills that I learned through being an iAcquire primary treating therapist with some of our WashU students and staff. As an occupational therapist, so constraint-induced movement therapy, or being that iAcquire treating therapist, was one of the hats I wear, but I manage our outpatient clinic, and then I still see patients. And so my primary practice area is with infants, so primarily infants who are discharged from the neonatal intensive care unit. I see them in the home. After their discharge, I work with them and their families to help support them as they transition to home until early intervention can get started. And so professionally, that's what I do. And then over to the right, that baby is actually my baby. I'm a new mom, something that I'm very proud of. And I have I have so much experience as a pediatric therapist, and so much more of an appreciation of what parents and families go through now being a mom. So that is a little bit about me. And so what are we talking about today? So we're talking about constraint-induced movement therapy. So we're going to talk about what is it, right? I know in the chat, I saw a lot of professionals here. So, right, you may have an understanding, right, of what is constraint-induced movement therapy. For any families, this might be the first time that you're hearing about it. So hopefully I can provide some information on what it is, right, some evidence behind it, why we do CIMT, what to expect, right? Especially for families, what can you expect during a therapy session, or for any providers that have never seen a CIMT session, have never had the chance to do it? What can you expect to see in a session? Really the importance, the role of play, one of those essential childhood activities. The title of the presentation, right? Play is the first word, because I think there's so much power in play. And I don't want to talk about CIMT just as a rehab technique, but as a rehab technique that is really integrated into what children do. And so that's play. Then you'll get to see a clip of me working with an iAcquire participant. And then I have my kind of thoughts on how can families navigate those next steps. So after you get all of this information, right, what are things that you can think about if you're wanting to pursue CIMT? For all of our providers that are joining us, right? These might not be questions that you're asking, but these are questions that maybe you'll encourage families who are thinking about CIMT to ask. So that way they can know if it's a good fit for them. Okay, so what is CIMT? I forgot to mention, because Mara did say that I was going to talk about the iAcquire study. So a lot of the primary kind of base for my experience with constraint-induced movement therapy is going to be as an iAcquire primary treating therapist. And so I had the joy of getting to be the primary treating therapist for the WashU St. Louis recruiting site. iAcquire is a multi-site national randomized control trial that is comparing dosages for constraint-induced movement therapy, and specifically geared for infants and toddlers, so ages 8 to 36 months old. Cassie kind of mentioned this. So children that do qualify for the study are randomized to one of three groups. That can either be the 3 hours a day, 5 days a week for 4 weeks group, the 6 hours a day for 5 days a week for 4 weeks group, or that usual and customary treatment. So essentially no constraint-induced movement therapy for a period of time, after which, when they've done their evaluations, they've kind of met that time period, then they have the opportunity to be re-enrolled into one of those 3 or 6 hour groups. And so in that study, we are looking, of course, we provide constraint-induced movement therapy in a child's natural environment. There's a couple of days at the end of that 4 weeks where we also work on bimanual or two-handed activities, because, right, we can work on an affected side, but of course we know, right, we interact with the world. A lot of things require two hands, right? We need to be able to use one hand to stabilize or two hands to hold things. And so we get to apply a lot of the skills and the motor development that we achieved through constraint-induced movement therapy at the end, with focusing on two-handed skills. The study is still active. So there are still participants going through treatment, right? Still going through evaluation, still getting that data, but not currently recruiting, because we've met our recruitment numbers, which is great. So I am no longer a primary treating therapist, since our site doesn't have any participants that are going through treatment right now. But when I talk about what is CIMT, just know that I'm going to talk generally about it, and then a lot of kind of my personal experience I'll share comes from being part of that study. Okay, so what is CIMT? So just generally, right, constraint-induced movement therapy, it's a neuro rehab technique, and it's really designed for improving upper extremity motor function, right? So hands and arms. It was originally developed for adults or for adults who sustained a stroke. Right, we're talking in the pediatric realm right now, but CIMT started in the adult world. A lot of the evidence and the research that was done with adults helped inform our application to pediatrics. But that's also where the pediatrics piece, right? We'll get to talk about play. When it was first developed, that's not necessarily what it was, right? In pediatrics, we're not just going to give a child, right, a task and say, hey, put this box in a block over and over, because that's not fun. And so when we talk about pediatric constraint-induced movement therapy, the principles, right, are going to be similar to what we're doing with adults, but we get to flavor it with our pediatric flair. CIMT is also one of the most investigated interventions for post-stroke treatment. The benefits of that, right, mean that there's a lot of literature and evidence that has already been done to show us that CIMT is effective for improving upper extremity motor function, for achieving these desired outcomes. And it also means, right, that there's more research and that's on the way because we want to refine our knowledge about it. Um, so when we think about constraint-induced movement therapy, for anyone that might have heard about constraint-induced movement therapy, especially if you're in the healthcare field, I've had conversations, right, when people are like, oh, CIMT, it's forced use, right? We'll get into that a little bit more. Constraint-induced movement therapy, right? It's not as simple as let me just put a cast or let me put something on your affected side to force you to use your less affected or unaffected arm, right? It's a very intentional therapeutic process where, right, we're using theory to help guide, right? How do we get these outcomes? So one of the core treatment components, of course, of constraint-induced movement therapy is going to be that C, right? You need a constraint. So we constrain the unaffected or less affected arm, right? And I have an analogy that will hopefully help you kind of understand why we do this later. But we do that, right? So that way we can really focus on the affected side without necessarily, right, kind of this distraction of an arm or a hand that a child, right, is most used to using. With CIMT, right, CIMT it's going to have high dosage therapy, meaning we're going to be doing multiple hours a day, multiple days a week for a specified period of time, right? It's not, when we talk about true CIMT, it's not something that's just kind of integrated as an activity here and there. It is a targeted, structured high dose approach. CIMT uses operant conditioning techniques. So for anyone that took intro to psych or things like that, as a reminder, right, operant conditioning, it's how we learn voluntary behavior. So we learn behavior through essentially what the consequences are. In constraint-induced movement therapy, we do a lot of reinforcement, and we'll get into more of that later on what does a session look like, right? But we want, in constraint-induced movement therapy, we want children to develop, right, improved motor function, improved use, improved independence. And we can do that, right, when they feel successful. Cassie mentioned that, right? When you feel successful doing something, you want to keep trying to do it. Or even if you feel like maybe you're not fully successful, getting close, and that gets reinforced or that gets praised, right? You're going to keep trying. And then mass practice, right? We know practice. I think, what is the saying? Practice makes perfect. We know there's no perfect, but practice, right? We need that to develop skills. Other core treatment components for constraint-induced movement therapy, right? Natural environment, I acquire as a research study, right, is intentional in making sure that that treatment that we provide to children and families is in a child's most natural environment or in a natural-like environment. Right, for some sites, they have participants that are traveling from out of state, out of town, and might be staying in a hotel room or an extended stay, right? We could easily bring those children into a clinic setting, right, like a therapy gym, but that's not what's going to be replicated. That's not where they're spending the most of their time when they're outside of therapy sessions. And so we know that CIMT is going to be effective when we can use an environment that the child is going to interact with pretty regularly, right? Because what's the purpose of practicing a skill in a clinic, right? And they know exactly how to navigate the clinic toys and the clinic environment, but it looks totally different than your home or your neighborhood. And so now you're putting extra effort in to try to translate that, right? Why put in the extra effort when you can kind of start from the get-go? And then the last piece, right, like I said, CIMT, it's done for, right, high dose, so multiple hours, multiple days, but for a specified period of time. It's not necessarily something that's going to be ongoing forever. And so there should be some type of transition plan for children and families, right? Whether that's recommendations for kind of their ongoing therapy team, things that families can practice in the home. Because again, right, practice is going to continue helping that skill development. We don't want it to just stop when the CIMT stops. Okay, so theory, I said we are going to get to that. So why, right? What is CIMT? Well, it's informed by theory, helps us understand, right? Why is it that what we do is going to help get an outcome? And so there's kind of two main pieces behind CIMT. The first one is that CIMT basically counteracts learned non-use, right? That can result from cerebral palsy, from a stroke, right? That learned non-use, I always tell my the parents I work with, right, children don't necessarily want to do something that's hard, right? And so if using an affected side is hard, right, they're going to learn that they can use the other side to achieve what they need to do quicker, faster, more efficiently. And so, right, they kind of learn not to use the affected side. CIMT helps counteract that because it shifts the attention specifically to that affected side. And so when we do that, CIMT promotes neuroplasticity. And neuroplasticity, right, is that fancy term for how our brain can change and adapt related to our experience, right? We learn through experience, we learn through consequences. And so CIMT targets that very specifically to help us achieve brain changes that are then going to translate to differences in motor function, right? Language development, cognitive development. There was actually a study that looked at MRIs from before CIMT and then 3 weeks after CIMT. And there was an increase in the gray matter volume. So gray matter is that part of the brain that processes sensory information, controls movement, helps, with cognitive activities like memory, decision making, thinking, right? So just from that one study, there are changes that we can see that happen in the brain after CIMT. So I'm going to use a garden analogy, right, to kind of help put this all together. So, right, you've got two pictures of gardens, but I want you to imagine that these gardens are two pathways in the same garden. They're not different gardens, okay? And that garden that's really nice and manicured on the left side, right? Easy pathway to find, that represents the side of the brain that controls the unaffected side of the body, right? So we're thinking in the context of a child who had a stroke. This is the side of the brain that controls the unaffected or less affected arm, right? And so you can see, right, that pathway clearly gets walked on, easy to find. And then we look at the other side, right? There's a pathway there. You can see it. It's not as easy to find, but it exists. But there are some weeds, right? There's some pruning that needs to happen, and there's some effort that needs to be taken to kind of clear a little bit more of that path so we can use it, and we can walk down the path more efficiently and more quickly. That picture on the right represents the side of the brain that controls the affected side, right? Or the weaker arm or the paralyzed arm. And so, right, what CIMT does is it basically puts a block going on the left-hand side and says, we're not going to use this pathway anymore, okay? We're going to try and use the pathway on the right. And it might be difficult, it might take some more effort to get through there to begin with, but as it gets used more frequently, right, we're going to start seeing those weeds move to the side, that brush is going to be moving to the side, and we're going to start to see a clearer path that we can walk down more efficiently, more quickly, that we can find more easily, right? And that when we look at CIMT, that's kind of what we're doing. We're trying to make those neural pathways clearer for the child to use, so that way they can continue practicing and then improving, right, their motor function in that arm. Okay, so that's what is CIMT. So why would we do CIMT? Okay. Now, I already told you, yes, top middle block, right? It helps improve upper limb function. But I'm an OT, and if you have no experience with OTs, or I think there's plenty of OTs on here too, they'll agree with me, right? Yes, motor function is important, and I care about that, but really I care about how that translates to function, independence, to how the child is going to be able to participate in everyday life, right? So for those of you that maybe have limited experience with OTs or no experience with OTs, I'll tell you, we as OTs, right, we focus on helping individuals be able to do the things that they need to do, want to do, enjoy doing every day of their life. And so for CIMT, we know that it helps improve upper limb function. But let's go even further, right? When we have improved upper limb function, when a child can use that affected side more easily, when it's stronger, more coordinated, it helps them be able to do the things that they want to do. Play, right? We're going to talk about that. But it also helps them build confidence. They can be more independent with the things that they're doing. Beyond that, there is evidence to support that, yes, we see the changes in motor function, but there's also kind of cross-domain benefits as well, that children that have participated in CIMT, don't just have improved motor function, but that there are also positive outcomes for how their language and their cognition develops, right? Other benefits of like why we do CIMT, right? We know it's supported by research. There's still research studies going on right now for pediatric CIMT, like that I acquire, and hopefully there's more on the horizon, right? But it's not because we don't know if CIMT is affected. It's because we're wanting to understand more. How can we make it most effective so that way we can use our healthcare dollars to fund it more efficiently, so that that way we can get more word out to families and individuals that will benefit that it is something that works, right? So that I acquire study is looking at dosage. We know CIMT can get positive benefits, but how many hours a day, can get us those benefits? Can we achieve it in 3 hours a day? Can we do it in 6 hours a day? Um, and so it's evidence-based, supported by research. And then other pieces about CIMT, different than some other therapeutic approaches, is that it really encourages family involvement. Right, CIMT is one of the therapeutic approaches that I get to do where I truly get to be like a train the trainer situation, right? I can do things and I can use my therapeutic knowledge to help promote skill development, but then I can help train parents and families and caregivers to be able to continue that outside of session so their child can continue to develop skills. And then we get to tailor it to the child's goals and interests. So, right, it's not something, yes, it's repetitive, but we try to make it as fun and as meaningful to the child as possible. Okay, so what to expect during therapy? So I'm going to bring this back in this core treatment components, because the core treatment components for CIMT are going to help inform what we're going to look for in therapy or how therapy is going to be delivered, across a program or during the session. So that first piece, right, is looking at the constraint. So we need something to be able to constrain that less affected or unaffected arm or hand, but there's a lot of different options, right? The one on the top left, that pink cast, that is the type of constraint that we use in the I Acquire study. It's rigid. It's the same material as like if you have a broken arm, that material, that casting material, right? It can be removed, but we make it specifically for the child, and we pad the inside, we cover it with Coban, more so, right, so they can't see any seams, they can't see that it can be taken off. Yes, tricking a little bit. Really, we're trying to take away any distraction of, I'm going to focus on trying to take this off. Right, that's one type of constraint. There are plenty of other constraints, and I'll say, right, I started my career in inpatient pediatrics and acute care, and we did not do full constraint, but we incorporated a constraint into some of our activities during sessions. And so we used things a little bit more like that top right, elbow immobilizers. We might slide it a little bit down more so that way it covers the hand, wrist, the elbow, right? So that way we were intentionally trying to get them to use their affected side to play or to achieve something. But there's plenty of options, right? You've got an air cast on that bottom left. Some places, right, are more focused on constraining just the hand and not necessarily the whole arm. So you've got mitts, right? But what you're going to expect in a therapy session is that a therapist is going to apply some type of constraint to the child's unaffected or less affected arm, hand, right? So that way they can't use it. And then, right, depending on how they're doing treatment, that constraint might stay on just for the session. It might stay on for the session plus a couple of hours after while the family is working on, continued practice. In the case of the I Acquire study, the constraint stays on 24/7, only comes off about once a week for skin checks, and then it goes right back on until the end of the study. So there's a lot of variability, and just depends, right, on how a place might be providing their constraint-induced movement therapy. High dosage. So, right, I mentioned that multiple hours per day, right? And when we talk about multiple hours per day, we're talking about at least 3 hours when we're talking about true CIMT versus what some you might see MCIMT, which is modified CIMT. Uses CIMT principles, but not necessarily that high dosage. With the high dosage, right, we're going to see multiple days per week of that intentional constraint-induced movement therapy with clinician. And then, right, there should be additional practice with caregivers and families outside of the sessions. And therapy teams or clinicians working with the child should be able to give some clear ideas or, help train caregivers on what are the skills that we're really trying to work on with CIMT, so they can continue that outside of sessions. Shaping and reinforcement. So this is where a lot of the magic behind constraint induced movement therapy is, that separates it from what people will call forced use, where I can take away your use of your unaffected or less affected arm and just say, have at it, right? Go and explore the world and go try and do what you can do, but I'm not really helping you develop the skills. So shaping, right? That's where we gradually increase the challenge of a task. So that way you can develop a skill. We especially, right, in iAcquire, we look to target specific impairments. So we're looking at really targeting, right, is weakness the impairment? Is that's what's prohibiting some of the motor use? Is it decreased coordination, right? And then we also want to be intentional about, right, if I want to work on grasping, so I want to grab something, there's a lot of other precursor skills that need to be worked on before I can really focus on that piece, right? If I see a toy 3 feet away from me, I'm going to need to reach with my shoulder and my upper arm. I'm going to need to extend my elbow, straighten it out, right? To grasp, it's really hard to grasp if my wrist is down. So I need to work on some wrist extension. I need to get that strong so that way I can bring my fingers up and I can grasp. Once I grasp, right, it's the coordination. Can I grasp with all my fingers? Am I grasping with one side of the hand? Am I strong enough to grasp? Right? There's a progression of skills that in CIMT we're very intentional about. If we don't have all of those precursor skills, reaching, straightening out our arm, lifting up our wrist, right? We might be able to work on grasping, but it might not be the most efficient, or the way that is going to be most beneficial for the child long term. Right? Sometimes if we don't focus on those precursor skills, we may be setting up the child to grasp now, but then to have future tightness or future musculoskeletal concerns, because they're not doing something, most efficiently. Right? When we shape, we have to do repetitive practice, but not just repetitive practice. We want to do it with specific functional tasks. Because, like I said, right, for any of you, right, separate from children, if I asked you to move 50 little blocks from one side to a box using your one arm, right, you're probably like, when am I going to do this? When am I ever going to move 50 of these blocks? But if I say, hey, I want you to practice moving, right, like loading your dishwasher or putting plates and cups up in the cupboard, you're like, oh yeah, I do this every day. And I want you to practice that actually go into that task, right? Because you're going to learn the best practice for a task is to actually do the task. With shaping, right, in CIMT, the child receives a model. So as a therapist, right, I'm showing the child, really exaggerated, you'll get to see in the video, how do we do something? I might give them some prompts, right? Reminders, hey, use left hand, use right hand, big open, big close. And then I want to give feedback on their performance, right? Nobody wants to do anything if they don't know that they're doing it well, or that they're doing it, correctly. And right, things aren't going to be perfect the first time. And so we want to recognize and reinforce, right, when they make attempts that look successful towards that final skill. And so reinforcement, right, like I said, we learn behavior, we learn movements, we learn that we want to keep doing things when it gets reinforced. And so positive reinforcement, right, is when something positive comes out of what we do. And so for children in CIMT, those reinforcements can look like things that are tangible, so like toys, right? I reached and grasped so I could get the toy that I wanted. It can be social. I reached and grasped, and my mom or my therapist started clapping and saying yay and giving me a lot of attention. And then it can also be natural, right? In CIMT, yes, play is a big piece, but we work on functional skills. And so, right, especially for a 6-hour day, like Cassie mentioned, her son participated in, we did eating as part of it, right? And the natural reinforcement when you're hungry and you grasp a fork and bring something to your mouth is that you got the bite of food when you're hungry. right? All those things help us continue to do a behavior and want to do it. Mass practice, right? So I have this picture here because one of kind of the simple ways I can talk about mass practice, yes, it's multiple repetitions, short period of time, few rest breaks in between, because we want there to be that heavy focus on getting that practice in. Think about cramming for a test, right? You're reading over things, you're trying to fit all of this information into a short period of time. You're not taking a lot of breaks because you're getting it all in at once. And so you'll even see in the video that we watch, right? Pay attention to, there's not a lot. I try not to have a lot of downtime, right? Even when we're doing a break, oh, okay, you're having a hard time grasping. Let's give our stuffed animal a big hug, because now I'm going to get you to reach with that arm and work on a skill. But it's integrated into place, so you don't even know I'm making you work. Okay. So the role of play, this is the fun part, right, of constraint-induced movement therapy, is that, right, in pediatrics, right, we want therapy to be fun for kids. We want them to come back, and we want them to continue participating. And so play is one of the best activities for us to be able to provide constraint-induced movement therapy in. This diagram comes from the Acquire framework. So this is kind of the framework that helps inform for the treating therapists and for why we do the things we do, right? Why we play and we sing songs and we use motivating toys, and right, we're constantly trying to turn things into play during therapy. This is the framework that helps guide it, right? And what I want you to pay attention to here with this framework is play is right in the middle, and it's in big bold. And it's in big bold because it's through play and the therapeutic interaction that just naturally happens, right, between the child and the play, the therapist and the play, therapist and the child through play, right, that we can facilitate movement, right, that we can facilitate them moving their arm, achieving a skill, right? We get to give them reinforcement through play, where play gives us the chance to do things repeatedly, right? Because if you have a fun toy where you get to drop like balls into, right, and it goes and it sings, or you get to press a button and it does something fun, there's already natural motivation to want to repeat that play. And then right through repetition, we get to refine a movement. And so that way we get to start seeing that movements get stronger and more coordinated. And so play, for families that are considering constraint-induced movement therapy, right, that'll be what we talk about, is think about, right, when you're looking at places that might provide it, is play a big piece of what they do, right? For therapists that are on this call, right, if you are providing CIMT or you aren't yet and you're thinking about it, right, how can play really be integrated to maximize what we're doing in CIMT? Okay, so now I have a video clip. It's about like 2 minutes. It is me. It is actually, I'll share, it was one of my first iAcquire participants. This family is okay with me sharing clips from our treatment. And so what you'll get to see is part of our therapy session where we are playing with a moose. It's Moose's birthday. And so hopefully you'll get to hear, right? I am masked because this was during COVID time, but hopefully you'll still get to hear the audio on how I help reinforce, right? I give praise, how I prompt this child to be able to use their affected side, how I give them models on maybe what they can do with their hand. But I think hopefully this will be kind of a nice chance to see CIMT in action for anyone that, right, even though we've talked about it for the past 30 so minutes, might still seem like a mystery of like, okay, you're saying all these things, but what does it look like? Okay. And then I'm gonna go ahead and play it, and then I'll just ask that Mara let me know if something's not working, you can't hear the audio or anything.
Is it baby's birthday or Moose's birthday? Whose birthday? Is it Moosey? Oh, Moose gets a big hug for his birthday. Moose gets a big hug. Okay, we gotta make it quick for Moose. Let's see what we have. Oh, what is it here? Ratty. Ratty. A baby cake? Do we need more cake? Oh, more cake? Okay. Reach with left hand. Good job reaching, lefty. Good job reaching, lefty. Oh, left hand got a piece of cake. Left hand got a piece of cake. Should we light a candle? Oh, I think Moose is turning 3. Oh, a candle for Moose? Candle goes on here. Yeah. Left hand turns. Left hand turns. Left hand push. Push with lefty. Good job. Oh, pull it off. You can pull it off. Good pulling with lefty. You know what? I think we need more cake. More cake? Let's see. Oh, close. So close. Here, try again. Close fingers. Here. Oh, did you get a candle? Can Moose blow it out? 1, 2.
Okay. Let me head back to the presentation.
Is it?
Let me bring back that presentation. So that was a short clip of just part of an iAcquire session. So you can imagine that for iAcquire, participants are randomized to either 3 hours a day or 6 hours a day. And so, we constantly trying to turn things into play. Let's see. Okay. But yes, hopefully you saw in that video, right? We're using toys, we're making it playful, right? I'm giving some cues, right? That video did not have some singing, so I spared you my sing-song voice, but right, sometimes, right, we're singing songs and we're turning things even like feeding ourselves into play. Right, because play is motivating. So if we weren't doing play, could I get my child that I'm working with to sit at that bench and work with me? That, like I said, is just a short clip of what was like a full 30-minute video that we took. And again, that's just a portion of the 3-hour session we did. So play is really powerful. So navigating next steps, right? This is especially geared for families, caregivers that are interested in CIMT, right? Things to think about. How do you find CIMT around you? So, right, the first place to go to is ask your child's medical or healthcare team. Also, because they can help provide guidance on, right, is CIMT appropriate for your child? Are they in a place that they'll be able to benefit? But likely your child's medical team knows of places close to you or in the area that help provide this treatment, because not every clinic provides CIMT as we've talked about it, right? Where it's multiple hours a day, multiple days a week, right? It's a high dose and really intentional, using that constraint to encourage use of affected or less affected arm, or unaffected arm. Another place to look for, right, is that, like we said, iAcquire the clinical trial. So there's a clinicaltrials.gov webpage. iAcquire is not currently recruiting, but you can see the locations that we're participating. And so, right, if you're in an area and maybe your medical team doesn't know of clinics that do CIMT, you can reach out to any of those iAcquire locations, because it's possible, right, that maybe, although they're not recruiting obviously for iAcquire, but that location may provide CIMT as an outpatient therapy, or they know of other clinics. I know at our St. Louis site, right, for any participants or potential participants who didn't qualify for the study, we're able to give them information about other clinics in the area that can provide CIMT. Other places to look, right, are pediatric stroke groups and associations, right, continuing education things kind of like this, and then parent and family support groups, right? There are parents, families, right, that have been through CIMT, just like Cassie, that can help, right, ask, and you'll probably find someone that can give you some direction on where to find it. But what are some things to consider when you are wanting to pursue CIMT, or you're wondering, should we do it? one of the first things always, right, or what are your goals? And what do you hope that your child is going to be able to do? If having improved upper extremity motor function is going to help contribute to that, right, then that's the first piece, right? Because everything with CIMT is intended to be, um, you know, goal oriented and targeted for the child. And so, right, CIMT should align with what your goals are and the things that you hope that your child will do or that your child wants to do, right? We talked about how CIMT has to be high dosage. And so are you in a place where you're ready to commit multiple hours a day, multiple days a week? If you're not, that is okay. That doesn't mean that you can't do CIMT. It just means that maybe it's not the best time right now, but that you could pursue it at a later point. Right, but it's better to know going into it, right, the expectation that there's going to be work on your child. It's going to be, right, an extra stressor. It's not just a 1 hour therapy session once a week, right? It's going to have more, there's going to be more time, more effort. Your child might be tired. I think Cassie can definitely speak to what her son looked like after our 6 hour sessions, right? Are you ready to commit to that and for your child to be able to be participating in that? Where is the therapy done? Is it in a clinic? Is it in a home, right? That can change, right, what you can expect to be the outcomes of CIMT. What types of activities does the treatment team talk to you about they're going to do? Right? Hopefully, play is one of those big pieces that they're going to talk about. Right? And that it's not just, oh, we have a list of activities that they do and they work through. We want it to be as functional and as meaningful for the child as possible. So, right, my tip is look for places that are talking about play, about feeding, about dressing, about the things that your child does every day. We didn't talk a lot about this in this presentation, but I'm going to mention it because it was part of the iAcquire study, right? Does the place that you're pursuing CIMT or that's offering it, do they do CIMT? And is there any type of incorporation of like bimanual training where they work on two-handed skills? So that way you can apply the skills that the affected side hopefully gained in the context of two-handed activities. And then, right, what does post CIMT transition look like? Do they give you clear guidelines for, helping inform your ongoing therapy team, things you can continue to do, maybe reasons or signs that you might want to consider another trial of CIMT, as the child develops skills or gets older and advances? So that is my piece. I know that I talked a lot, and so now hopefully I'll have some questions or things that people want to discuss with me and also Cassie, because like I said, Cassie can provide that lived experience for anyone that has questions about that. So we can head right into Q&A. And I will stop sharing.
Jump in.
Oh, just a sec. Thanks so much, Maria and Cassie. Yeah, Rebecca, go ahead with your question.
Yes, thank you so much. This has been so helpful. I appreciate both of your insights. My question, I put it into the chat, but I'm a school-based therapist and I work with the preschool, so 3 to 5-year-olds. And one of my students has tried CIMT in the past, and he apparently lost 5 pounds during the process, just because of, not being able to feed himself as much. And I don't know the whole situation, but just looking from a school perspective, they're planning on doing it again in the fall with him. So him coming to school with a cast, and he does preschool 3 hours a day. And so my question is, like, what is our role as therapists, during CIMT and during the school setting? Like, are you helping children feed themselves at all? Are you waiting? Like, what's the just right challenge with CIM and CIMT?
Yeah, good question. So the piece that I'll address, right, is like how can we as therapists help it, right? So I know I talked a lot about play, but right, we can address any functional activity during CIMT. And so, right, Cassie can speak to this too. I mean, we did what, like 2 meals in that 6 hour period, Cassie, for your son. So, right, I intentionally do want to work on feeding, right? How can we be successful with feeding with our fingers or our hands, using utensils? Right, one way is that if he's doing outpatient CIMT, right, that coordination with his primary CIMT therapist can be really helpful, because I know that when I work on it for I Acquire participants, right, I make sure to show caregivers some strategies on what makes it a little bit easier to grasp a utensil, right? There's some kind of quick, simple tips that we can, or tricks that we can do that make things easier. And so his treatment team hopefully can provide you with some of that you can carry over into the school setting. Right, I think when you're seeing a child that has the constraint on and is actively in CIMT, right, his primary team can really help drive some of the strategies you can apply, so that way you don't feel like in isolation. You're like, I need to problem solve this, right? Hopefully you can tell the treating therapist, this is what I'm seeing, or these are the types of tasks that we work on in school. What are some tips on best ways I can incorporate, right, constraint into that? Does that help answer?
Yeah, thank you so much.
Yeah, of
I'll
course.
I'll just add when my child was young and we were doing constraint, just like highly motivating toys are incorporated, highly motivating foods can be incorporated. So almost anything can be made into a finger food, like strips of French toast or things that you can dip or, finger paint with yogurt, those kinds of things, blueberries, puffs. So there's, like spirit of playing with the food that maybe you don't want to encourage at other times, but maybe it's more tolerable when it's for the purpose of CIMT. So I'd love to generate some discussion. If there are families here who have questions or thoughts or who've participated or might want to participate in CIMT, please join us. If not, if there are other professional questions, we'll take those as well.
Hi, can you hear me okay?
Yep.
Yes.
Hi, my name is Alex Haney. I'm a pediatric OT in Boston at an outpatient pediatric clinic. Typically in the summer we do a CIMT camp. That's like 3 weeks. This summer we're not doing it, but I think we are seeing a couple of kids for like a CIMT like intensive. And I was wondering if you have any like favorite like activities. I really liked the idea of like having like two toys that you can like pick from, where like they still have to like reach, and then like having like a bucket that like allows you to like reach and then also like grasp and have like that high like repetition. But do you have any like other like go-to like favorite activities?
Oh, yes. Yeah. So the bucket is one. So a lot of these activities I learned. So as I acquire primary treating therapists, we actually go out to Virginia Tech to do a couple days training. And we get to learn a lot of these strategies. So like my go-to is that bucket.
Mhm.
That bucket comes out in like every activity, because it is a really nice way to grade movement. So you can move it higher, lower, and it's a pretty clear target, right? Especially if you use a little bit
Mhm.
of a wider bucket for them to actually get their hand into, versus if you're holding something, right? We think that we're holding it steady for them, and then they're like trying to navigate. We're making it harder for them. Also, it's hard to grab something from someone's hand.
Mhm.
Right, a bucket lets you kind of like drag it out or grasp it. Buckets and lunch boxes, like the old school like metal lunch boxes where you can pull it open. Cassie's nodding her head because we know that Morgan really liked that. Right, they can use their fingers to like learn to grasp and pull it open to find things. So like hide and seek. um Especially, right, like Mara said, if they have motivating toys or figurines, cartoon characters, right, that you can put in there. um I also like using pots. So when we think about functional things, pots with lids that they can
Okay.
grab, so that way you can hide things. Right, as they get stronger, if it's a metal pot, they can hold the handle, and it, right, it's extra weight.
Hmm.
Um, and then my other go-to is a salad spinner. Again, right? So it's a functional thing that probably people have in their kitchens, but we can turn it into a toy. The salad spinner, especially the OXO one, has a push button, so you can
Oh,
use it for
excellent.
weight bearing. right? If you hold it vertically, you can use it to grasp it off. But I love using that for sensory play, right? Throwing beans and jingle bells, water play, right? Again, favorite toys. Oh, they're going flying. So yeah, those are my go-tos. And it's more because if you have those pieces of equipment, you can usually do a lot of play with it.
Wonderful. This is super helpful. I'm going to have some kiddos like in the next coming week. So this came at the perfect time. So you gave me lots of ideas. Thank you so much.
Yeah, of course.
Oh, I was just going to add for summer, water, of course, is really fun. Um, so any kind of splashing or pouring.
Mhm. Yeah, bubbles too. Those, especially those big blonde bubbles.
Oh yeah, we love those here. Wonderful. I'm just writing all of this down. Okay. Wonderful. Thank you so much.
Yeah, of course.
Cassie, is there anything else that you heard from Maria that made you think of something that you want to share? You're muted.
Thank you. Yeah, no, when she was talking about it all, I was just getting flashbacks to when I was doing it with Morgan. Now, with Morgan, he was younger. So, like, we didn't have to worry about toilet time because I wasn't worried about him until he started walking, and he didn't do that until he turned 2. But just all of it combined just really shows like how much they're capable of, and making sure that they continue to do that is going to be the most beneficial thing for them. Like for me, I wore braces when I was a kid. My son wears braces. We all know that they come a long way, but they still can suck. And I try to give my son as many breaks, small little breaks as I can from them, so he'll want to still wear them, because there was a time where it got too uncomfortable, it got too painful for me, and I just was done. And my mom, she let me because she saw how hard it was. But we both wish that we didn't do that, because I could be so much further now if I continued it when I was that young and had more ability. Like, yes, we can still do things as adults, and we want to still continue to strive and see things that we might not think that we can do, and say, let's do it anyways. Let's go for it. If someone else can do it, why not me? And so if we just keep showing them that they got this, and it's hard, but it's going to be so worth it, is the best thing I can think of.
Thanks so much. I'm going to put out one last call for questions. Anyone else want to share a question, or if you've been a practitioner providing CIMT and you want to add something to the conversation, we'd love to hear it. Okay, Maria's put her contact info there. And I'll just thank everyone again. Thanks for coming, and hope to connect with you again soon. Have a great afternoon, great weekend. Thanks, everybody.
Thanks, everyone.